Live from New York, it's Benefits with Friends. I am Lou Bernardi, your host. We have a great episode for you today. I'm going to bring Leo Wisniewski into the streamer. There you go. Leo, how are you?
Hi, good morning.
Did I say your last name right? Wisniewski?
Wisniewski.
Wisniewski. Jeez. I was so close. It's a kind of exciting day, big episode. Title of today's episode is Consumerism Meets Healthcare. And obviously that might sound strange to a lot of people, but, because the term consumerism has been used within the managed care healthcare space for a long time. But I think we would agree, and we'll probably get to it in the conversation, that, true consumerism is just beginning. And I think consumerism is really like empowering the consumer to make better choices, not penalizing them with higher out-of-pocket costs for making bad decisions and trying to drive them to certain facilities where the system makes more money off of everybody. But so I'm gonna do a little bit about your background, and then you can add to it, because this isn't Hollywood, so it's not really rehearsed that well. So 15 years at Blue Cross Blue Shield. Those roles include Actuarial Analyst, Contract Analyst, Payment Integrity, Informatics. So I need you to tell me what that is, because
it's just data science. It's data modeling science. Claims data.
All right. So you're a numbers guy. There's no question. always been. So basically, in those roles, you modeled claims data to project spend, like a claim spend, right? For the individual market, the group market, whatever, I guess. Created fee schedules, supported contract negotiations with the facilities, the doctors and the facilities, right? Yeah. Identified incorrect claims. I'm assuming probably that we're in favor of Blue Cross Blue Shield if you found claims that
that's right.
Favored the patient.
If we overpay, we keep our mouth shut. But if we underpay, vice versa.
Everybody's trying to find a nickel these days. Payment policy impact, right? So did I do a good job? I feel like I did a pretty good job.
You did, and it was funny because, like when I worked at Blue Cross, I loved my job. You call me weird, but I loved going to work and I hated leaving because there's nothing more fascinating than changing the way people get paid and watching how they react. It was just, there's nothing more interesting than that.
Yeah.
And
how they react, how the consumer reacts.
How the providers react. Because
the providers react, right?
And what I saw, like in the beginnings, it's very complicated. I would pull lever A thinking, I just saved money. But it wasn't until like 3 years later where I realized, well, wait, there's something happening here. Like they're changing their billing patterns. So whenever I pull a lever, either the change in a policy or reducing the fee schedule rates or calling money back, there was a reaction by the doctors to change the ways they bill to choose codes that recover the money that I just took from them. It was never the air never went out of the balloon. It was just always inflating, getting bigger and bigger, because doctors and hospitals, they're just changing the way they get billed because managed care companies, they're trying to claw money back to hit their recovery goal. And it was I think it was an unethical business practice.
Sure.
And it wasn't until I didn't know this until like 8 years into the job, that there's this cat and mouse game within managed care of this, I'm going to get my money, and just constant fighting while the consumer lost. And
always, right? Yeah, the consumer always loses.
It was just against my value system to, participate in this unethical business practice. And so what happened was, I showed management the reports that, hey, the doctors are changing their billing patterns to what you're doing. So the money you think you're saving isn't saving because they're just changing the cost somewhere else. It's not coming down.
Right.
And they hated me for that. They did not want. They put me in a closet and pretended I didn't exist because they didn't want evidence or data or the story that this isn't working. They were just in their silo, their heads down. This is what I do. That's not my job. Get away from me. and it was horrible. It just made me miserable.
Well, it's funny that you bring that up, because I talk about that quite a bit, and I've been doing this for 32 years, and I was there at the beginning of when managed care, really became the predominant form of health insurance and healthcare, and the driver of the change has always been that the consumers, the cost to the consumer has been going up. So managed care seemed like, in the early days, like it was going to be the saving grace for the consumer, because, these insurance companies were able to create networks and kind of force what at one time probably were true discounts, right? Getting discounts off of the true rate of care. But no one in business, this is huge business. Healthcare and health insurance is huge business, right? No one just sits there and say, oh, shucks, we're going to make less money. At the highest level, both of these forces, healthcare and health insurance, are trying to use their leverage and their power of the pen. Those contracts are so important to earn more money, right?
Yes.
And what I'm kind of hearing from you now is, you were changing the way that these contract negotiations were going, right? And it seemed like a good thing. They could say, oh, wow, we're getting bigger discounts. But the healthcare system was sitting there saying, what are we going to do about it? And it was a manipulation of the numbers. They might make less money unit cost wise, but now they're going to change the codes.
Build more units.
Build more units. Right. Created more quantity, not higher quality.
Right. And does anybody think a boo-boo is a level 4, episode? But
Every
it is.
PR in the country does.
Yeah, but it's funny because that boo-boo, they'll bill a 99284, level 4, a very high acuity, and clinically, that doesn't make sense. This level of acuity doesn't line up with a boo-boo.
Of course it doesn't. No.
But let's think what's happening here. The insurance companies are clawing money back where they shouldn't be. So the only thing hospitals and doctors can do is upcode and build more units to get the money back that they need to be solvent and run a successful business.
Yeah.
So it's unnatural to claw money back from businesses. They should be allowed to operate as they do, as long as they're transparent.
Right.
If they're transparent, there should be no interference in how they run their business.
Have you come across slingshot bills yet?
A little bit.
Yeah. So their whole their technology is based on reviewing all claims, and they've discovered in a short period of time that they've been running their technology through TPAs and everything, that 60% of codes or of claims include upcoding. That's how predominant that is. And
it is. But
very little of it gets captured.
But my point is that it's not entirely wrong when you're when you're causing abrasion for the sake of hitting a recovery goal.
Mm-hmm.
So don't interfere with their business, and they won't upcode. Don't poke the bear.
Right.
That's where I'm coming from. I don't deny it's there, but I'm saying the reasons why it's there is because the business practice of clawing money back is unnatural.
Yes.
And so what Health Cost Labs is about, diffusing the situation, putting the transparent information in front of everybody so we don't have this abrasion. And when we don't have the abrasion, the cost will come down.
Right.
So
right.
I'm not arguing that there's upcoding there, but I'm saying that the forces that are causing the upcoding aren't being discussed.
Yes, correct. Right.
So that's the mission of Health Cost Labs.
Yeah, let's talk about that. Let's talk about Health Cost Labs a little bit, because you're very advanced, I would say, in what you're doing. You're taking a tremendous amount of data. So if you want to give a little bit of history of how you got into what Health Cost Labs does, what they do with what they are able to attain, and then we'll talk a little bit more about the vision and maybe the impact it's that you see it may be having on the market.
Thank you. So 3 years ago, in July or August of 2020, the First Circuit Court ruled that, Trump issued an executive order in May of 2019 saying hospitals had to post their prices. Hospitals sued. The courts ruled in June that the prices must go forward. And then so in October, the appellate court ruled that it stands. Prices will go forward. So in 3 years ago, I was gearing up for building the database structures, anticipating the files that will come online. I need to load them. So 3 years ago, I'm like doing homework, preparing the databases and the design, anticipating these files that came online in January 2021.
And because of your background and your history, you knew already the massive amount of data that was going to be released, right? You had seen the data. You had spent 15 years doing that already.
Yes. So I knew exactly how I need to prepare the database to ingest this data. So I had inside knowledge, which I was using.
Yes. Great.
And that really helped me out. So when January 1st came of 2021, I started, open up these files, and of course they were presented horribly, but it's nothing no programmer can't straighten out.
Right.
And that's what I did. And it was a lot of hard work the first 18 months of coding up all these scripts to ingest the data that was presented horribly, but we got it done. And really, I thought the problem with healthcare was that there was no price transparency. If I just put the transparent data out there, we can have a different conversation, diffuse tensions, and costs should come down. And that's not what happened. I built it. I thought they would come, and very few came. And that's where I realized the real problem isn't price transparency. It's conflicts of interest. It's people making money doing, something that made sense before price transparency, but they're not changing their business practice to do business a new way. They're still doing reference-based pricing or.
When you say they, who are you expecting to?
Well, businesses, like I don't want to name names, but
yeah,
if we have if a hospital says the lowest amount they accept as payment in full is $500, and maybe that $500 is 110% of CMS,
right?
Medicare. Why are you paying them 140% of Medicare if they take 110%? So they're not using the price transparency data to lower the cost, because their business practice, which made sense before price transparency, but they're not changing their business practice, that surprises me. And so just people are just not realizing that we don't need to force plan designs and limited networks and contracts when we have price transparency. So that has been a real eye-opener to me. And they're not changing it. So
right.
So what we're here now, we're releasing a mobile app today.
Yep.
It's called Billy.app, and it's a direct-to-consumer tool to allow them to price shop, to see. And I'll demonstrate it in a few minutes. But it's going to allow them to see lower-cost alternatives in their market, and so they can just get in their car or walk a block to a different hospital or doctor and pay a lower cost. So it's a different way of approaching healthcare. So that I feel that the only way we're going to fix healthcare is to empower the consumers to make a different decision. Right. I'm not telling them what they should make. I just want to make sure that they have the information so that they are empowered to do things differently.
Right. So they can become an informed consumer.
Yes. And then the businesses will have to adapt to the consumers because on their buying powers. Because that's how an economy works. Businesses react to the consumer's buying power, not the other way around, which is what healthcare is.
Well, when you go, one of the things again I talk about is that these two forces, the healthcare and the health insurance, ecosystems, they know about this, right? They know what's happening, and they are already probably people that were in your role that you had before are trying to determine the impact of new consumer behavior on their profits, right? What is the consumer? How quickly are they adapting to this? Now, because we would not have a managed care system if it hadn't been the consumer, right? The indemnity companies that existed prior to managed care would still be in business if that's what the consumer continued to purchase in the early 90s. But all of them went out of business, right? Because the premium dollars went to managed care. And it was a heavy lift for advisors and plan sponsors to make that change, because there was a lot of education around this is how managed care works, co-pays, a lot of new terminology that didn't exist before, directories. We had people thumbing through directories, and this plan sucks because my doctors aren't in it. And I would literally have them chucked at me by business owners and CFOs because this plan sucked. But the consumer made the decision ultimately. So now this is going to be a slow adoption, in my opinion. Probably, right? It surprised you that more people weren't like starving for this information, and still probably you'd admit most people don't even know about any of this stuff. Most plan sponsors, they might hear the commotion, but if their advisors and their insurance companies aren't talking to them about the power of transparency and what this data can actually help them do. Now, so these files, right? Because most people don't know this, right? And hopefully this whole show is really about, it's called Benefits with Friends, because it's like me sitting around, coffee table with my friends on the weekend and talking to them about the things that I've, learned about healthcare. So I'm hoping the people that actually listen to the show are using it to become more informed, because information is power. So now this data, let's just say hospital A. First of all, quick question, and you probably know this. What percentage of hospitals have complied with this law so far?
So thank you. So in the beginning, I made some mistakes. I would pull a file down and I would see the negotiated rates and say, it's compliant. Next file, compliant. Next file, not compliant. And then I got myself into trouble because compliance has many check boxes. And compliance isn't just one checkbox. It's like, did you have this code? Do you have the cash rates? Do you have all these little plan names? Do you have every code? And I wasn't doing I was not interrogating these files rigorously like I should to label a hospital file as compliant or not. So I kind of remove myself from that. I just say, hey, here's the file. I'm not speaking to compliance, because that's a deep well.
Yeah.
But what I'll say is that most files are full and robust. Okay. And, one of the CMS 70 shoppable codes is a knee surgery, DRG 470, and a new patient code, 99203. Well, if a hospital doesn't do knee surgeries, they're not going to bill DRG 470. So just because that file's not in there, that technically they're not compliant. That file's not in there, but they don't have utilization for that code because they don't do it.
Okay.
So it's a really difficult thing to label on, put a label on somebody when there's so many reasons why information may or may not be there. So what I can tell you is that probably 90% of the hospital files are full and robust, offering lower cost alternatives.
Okay.
So, and I'll show you, you're going to see the app pretty soon. You're going to be blown away when you see the amount of pricing information in any part of the country. And you're going to say, why are we talking about compliance when we should be talking about why are we paying more than the lowest rate?
Right.
And that's where I find when I go on LinkedIn, people are not talking about why are we paying more than the lowest rate. They're talking about, 140% of Medicare or upcoding, and they're talking about all the wrong things, which is frustrating to me.
Well, let's talk about that for a second. 'Cause I know you get a little bit of pushback from the industry, because we can't assume that you can walk into a facility and say, I want to, you accept this rate, so that's what I want to pay. That probably won't happen. The more people that walk in and do that, the ecosystem, the healthcare system has to adjust, right? More people, if people take their business elsewhere because another hospital or facility or outpatient center says, yeah, we'll take that all day long, then again, the consumer is going to drive the market, right? The consumer behavior. But if a hospital's required to accept Medicaid and Medicare, right? Because they got the government that they're dealing with, but they either lose money at that rate. If everybody came in and paid that rate, they'd close their doors. They would, because they can't turn a profit at that rate. But that doesn't mean it's still not useful. Again, because of what I'm saying is that, the more people who are informed and have the power to negotiate a better price, either on their behalf or maybe their plan is created in a way that uses this information to pay fairly. That, for me, I want to pay fairly. I don't want my insurance carrier manipulating that rate because it drives their profits.
That's right. So let me speak to that. So thank you for that. So I don't deny 99.9% of people will not know the code they need before treatment. That's a post-treatment piece of information. But what we can see is cheaper locations.
Yes.
And so upon introduction, which I'll show you in a few minutes, you're going to see lower cost locations. Let's start there.
Right. A map of some sort.
A map. And you're going to see it. We're going to start there. Now, when I get billed after treatment and I get, pick any code, let's say it's paid $900, you can also use the app, Billy.app, to say, well, you charge me $900, but you're accepting, $300 from Blue Cross or Cigna, or maybe your cash rate is $300, but you bill me $900. So there's two purposes for this app. It's identifying the cheapest front door. That's you won if you do that. Yeah. And then you're going to win again when you can confirm that you didn't get overcharged.
Right.
Now, I don't deny that hospitals have a patient mix where they expect, revenue from there to, generate this much money to pay their bills. Yes, the numbers are going to move. Some are going to go up, some are going to go down, but hopefully, in like 5 years, you will have parity.
Right.
You're just getting a fair rate. You're not getting hosed. You're not making a great deal. You're not, look what I won. It's fair rate for everybody. Right. And then we can stop this managed care nonsense of contracts and clawing back money back, because it's a direct payment. I wasn't ripped off. I knew what I was charged before I got treatment. I'm not defrauded. Don't claw money back from a doctor or hospital who's engaging in good faith.
Right. One of the important regulations that stood up in court is that patients with insurance can still elect, and the hospital has to allow them to pay the cash price instead of their insurance price.
That's right.
Right. Now, what's real important, though, is you can't use your insurance. You can't submit it through insurance if you have an insurance company that pays based on a network rate. Right. Because once that claim is submitted to your carrier, they're going to take that code. They're going to plug in the EOB, the allowed rate, the billed rate, the allowed rate. That allowed rate becomes your rate now. So even if you agreed in advance to pay the cash price, I think that submitting it through your insurance company is going to present a problem, because we know, and I want to talk about the cash price, because for me, that's really probably the most interesting bit of information and people aren't aware. You've seen these prices now for several years. How often is the cash price, meaning I'm not using my insurance, I walk in, I don't have insurance. How often is the cash price less than the insurance carriers negotiated discount rates?
I would say 90% of the time. the cash rate is not the highest rate.
Mm-hmm.
It may not be the lowest. It's going to sit above the Medicaid rate and somewhere around the Medicare rate, but it's not the highest. And that's what really surprised me in the beginning when I saw cash wasn't the highest rate.
Right.
I'm like, well, what is mass buying power if cash is the cheapest rate?
Right.
Why am I paying premiums when you can't even get me a good rate for your mass buying power? This is so messed up.
As an advisor who tries to build these plans using all of this information, which is, this is technology, right? This is data and technology, and that, this Billy.app is going to be, instrumental in getting the information out, not only to the consumer, but think about the competitive nature this is going to create within the healthcare system itself for facilities, maybe independent outpatient surgery centers like Oklahoma City Surgery Center, who post the cash price every day, right? And there's going to be more opportunity for companies that don't want to gouge the marketplace to be able to say, hey, come here. We're an open book. Go on our website. You could take their price right today and say, oh, here's the cash price. I'm assuming their price basically is the cash price, right? That's what they will pop up when.
And I want to speak to that. Thank you for that. So clearly, there will be jobs no longer needed in healthcare industry because price transparency, it replaces the need. I'm speaking to payment integrity. I'm speaking to data analytics. I'm speaking to contract negotiators. Like that line of services is kind of no longer needed.
Right.
But that doesn't make the people's knowledge. We still need your knowledge. The work you do has been replaced, but we still need you to help people shop. There's a massive consumer education effort that will be needed.
Yeah.
And the people who know how payments work will be needed to guide people to make these informed decisions. So your work product changed. We still need you.
Yeah.
But I'm just asking you to hey, let's stop forcing this work product that's no longer needed. Please stop doing that, and get behind consumerism, because that's where we need you. We just need you in a different role. We still need you, just in a different role.
Well, think about what you were doing, right? You could argue that you were on the dark side before. You were working to help the insurance company, but now look what you're doing with that massive amount of intellectual knowledge that you absorbed, right? You could still be doing that. I'm sure that role pays pretty well, but then once you have that aha moment and says, wait a second, none of this is being used. Like, I was naive. I was selling insurance for 26 years. I was a general agent. I was helping, hundreds of brokers, thousands of clients for a very long time. And I thought that I was, doing a great job. And, based on the old, standards, I was always negotiating the lower premium, but I didn't have a full deck of cards to work with. Yes. Right. I had no jokers. I had no picture cards. I was playing blackjack without any, anything above a 9. Right. And, you could win. It could feel like a win, but is it really a win if you know that there's people out there, members, patients, who are suffering, who can't afford their medical treatment, can't afford their prescriptions because the leverage of the healthcare system and the health insurance, marketplace isn't even though what's the word? I can't. I'll think about it in a second. They have to give the impression. If you go on any insurance company's website or any healthcare system's website, they're gonna talk about the good they're doing for their communities, right?
Yeah.
That's the impression. They have to do that. Once they lose that, any sense of goodwill that they're actually providing for their communities, they're done. They're toast. They're the enemy. And I'm very conscious of that. And I thought, wow, I can't unsee what I've seen. So I got to make a decision. Do I get out of this business completely, or do I work harder and fight a fight that, to my surprise, just like you thought everybody would if you build it, they will come, right? And eventually you're going to get to that scene at the end of that movie where there's a line of cars
Right.
that goes past the horizon. I mean, it's going to happen,
Right.
because
And I think
has
that
to.
the best thing insurance companies could do, because everybody needs to insurance for something catastrophic. I don't deny they need to be there.
Sure.
They should honor the lowest amount the hospital or doctor accepts as payment in full. Let the member pay cash. Let the member take that receipt, mail it to the insurance company, and let them get reimbursed so they can apply that to their deductible.
Right.
They can do that. There's no law stopping them from doing that. Okay? They should have the decency to recognize that now that we're in post-price transparency, these rates are unethical. I shouldn't be forcing my members to pay 10 times more than the cash rate. That's wrong. So let's stop the silliness. Let's stop the dishonesty and recognize that the contracts in a price transparency world don't work. We need to reinvent ourselves to be relevant in the new marketplace. And we're going to do it by honoring the lowest amount the hospital doctor takes payment full. We're not going to call money back from them. Let them bill whatever they want. I don't care. As long as it's a fair rate that the member paid up front, I'm going to reimburse it, and that's it. That's how insurance should work.
Yeah. Who knows? I mean, I think 5-10 years from now, both industries will be very, very different than they are today. I'm not sure that the networks of today will still be here. They've shown that there's no value, right? They haven't. In my opinion, hospital systems, these are real estate companies, right? They own a massive amount of property, real estate. The tax advantage that they're getting is astronomical. The goodwill that they're doing for the communities isn't nearly what they should be, and what they really are required to do, right? There's one town, I think it was in Illinois, not too far from Chicago. And I think it was Dr. Marty Macri who talked about this at one of the conferences I went to a couple of years ago, where 50% of the population of this one small town that was at the mercy of one hospital was in collections. 50% of the residents of a town were in collections, and if I'm not mistaken, that they brought a lot of public attention to that, and I want to say it was wiped away, but that's happening throughout the country. There was one time when most hospitals were independent, but to your point, what you discovered is they had the access to the same data as you. Right, the hospital systems were sitting there with their people in similar roles to where you were at Blue Cross, and they were crunching the numbers and said, probably at some point, if this continues, we're out of business. So what are we going to do about it? And what they had to do is they had to merge. They had to merge with other hospitals. They needed strength. Right. They needed to be able to say, you can't sell your insurance product without our 5, 10, 15, 30, 40. There's networks of 100 hospitals in this country. Do you think you can write enough insurance in a particular market if you don't have majority of the hospitals in that market? Because the consumer is still obsessed with the network. Yeah. Right. And that's the thing.
I'm hoping Billy is going to change that real fast. So because may I share my screen so I show it to you?
Yeah, let me I think let me see if you
I can present.
Oh, perfect.
Share screen.
I might have to let you. I'll see how this works.
No, I think I can.
All right.
Hold on. Oh, here, Billy.
I'm going to probably have to pull it up on the screen. So there you go. Okay, I see it. Okay. I'm going to add it to the screen. So there we go. Awesome.
Okay, so this is Billy.app.
This is the Billy.app that's going live.
This is the Billy.app.
Wow.
Yeah, it's great. So it's $10 a month, and you can buy for 1 month and drop it, or pay $100 a year for full unlimited access. So here we're looking at, I want to zoom out. So we're over, New Jersey, New York, Philly, and this is code 74177 down here in the corner. But I'm going to zoom in. and it'll be faster, but it's slower because I'm sharing my screen. But the performance will be faster.
That's 1713 right there. That's basically where I'm sitting right now. That's Long Island.
Yeah. So we see here that the average rate in my visual is $1,507.
Oh, that's what that number is in the center of the screen, is the
That's
average
the
over
average
that
rate.
geographical area? Okay.
In your visual. So we see here that we see a $457 amount, and we see a $5,240. That's $4,800, probably a 1 hour car ride with traffic between these two spots.
1,200% markup.
I don't know what the markup is. Yeah. So if I click on it, I can see it's JFK Medical Center. And if I click on the detail, this is working.
Oh, you got to subscribe.
What happened here?
That's okay. Actually, when you hovered over it, it gave some info.
Right. I guess the programmer this is working 1 hour ago for me, and but what happens is when you click on the detail, come on, it's going to show you all the different cash rates and plan names.
Right. So I'm looking at it because this is going to this is going to be live where people will be able to see the video. But for people who are listening as a podcast, what we're doing right now is we're searching a code. It's a CT of the abdomen and pelvis with contrast. The average rate over a pretty big market area is $1,559. And then when Leo hovers over, so hover over any one of those.
Yeah. So I'll choose I'll pick over here your Long Island.
Yeah, 1713 there. So
that's Mount Sinai South Hospital.
South Nassau Hospital, Mount Sinai. So that's in Oceanside, New York. The cash price is $1,700. The lowest insured price is $109, which I'm going to assume is Medicaid, possibly. The average insured rate is $808. So here's a situation where the cash price is actually pretty high compared to the average insured price, but the highest insured price is $5,172. And this is what this facility bills based on what type of patient you come in with, right. Who's your payer, essentially.
And then Lou, look at this. It's like I can zoom in, and there's another hospital, up the Long Island Expressway for 800 South Shore University Hospital. So the cash rate is $881. It's 50% cheaper, the cash rate. Yeah. So why would you pay $1,700 when you can pay $800?
And this is particularly powerful for people without insurance or people with HSA plans on the marketplace or through their employer where they might have a $17,000 family deductible. They're paying $2,000 a month in premium here in New York for a plan that doesn't cover anything except for preventative care until they've accumulated $17,000. Well, you can use this, and there's a 447 up there on the top left if you want to drive that far. Oh, right there. Yeah, I think that's Manhattan. Yeah, that's Manhattan. Cash price $447.
Isn't that amazing?
So you could call there. You get a prescription from your doctor, specialist, whoever. You've gone to the doctor. You call them and say, okay, this is what you need. This is the code. You get the code from them if you're a savvy consumer. You go on this map and you say, okay, where can I get this? Well, is it worth $1,000, $2,000, $3,000 to drive an extra 30, 40 minutes, an hour?
Yes, it is.
Give them a call and say, I'm coming in. I'm a cash patient. I want to pay according to my resource. Your cash price is $447. Can you double check that? Book me for next Wednesday at 8:00.
Right. And get a good faith estimate with it in writing. That's the law.
Right.
And so let's go over to Houston. I want to zoom out and just take a shortcut.
And people who purchase this app, they have access to the entire country. That's not like a regional
unlimited downloads.
Interesting.
It's unlimited. So here we just did sorry, it's moving a little slow.
No, it's fine.
But we just found the cheaper front door. You can also do your own payment integrity checks. You know, maybe if you had for some reason I can't get to it right now, but you'll have access to the detail where you can simply, check it. So let's change the code.
While you're doing that, so for people who are listening to the podcast, what Leo's doing with this app on the screen is he's just scrolling across the country, and as he stops in a particular area, zooms in, zooms out, whatever you want to do, it populates all the prices in that area. So right now we're looking at Houston, Texas. We're looking at a mammogram.
Yep.
Including, I can't see what that says.
Here we see
gadolinium, I think.
It's a DX mammo, but so here we can see East Houston is $1,200, and Memorial Hermain is $135. But what's also here, which we can talk about, you see all these little blue dots.
Mm-hmm.
These are your urgent care centers and your minute clinics and imaging centers. So we are informing you of other sites of services that you may not be aware of that you should be aware of. Say, hey, maybe I don't need to go to a hospital for a bee sting. Maybe I can go to an urgent care center.
Is the price that's being highlighted there? So the $1,242 and the $251, is that always the cash price that's showing?
Yes. So where the hospital?
Cash?
So see here we have an asterisk. If the hospital didn't post the cash rate in the file, we're saying here this is the average commercial rate.
Okay.
So it's a way of me forcing compliance on them if they didn't post the cash rates.
Now, if I subscribe to this, right? So if I have this subscription for this, and I now click on it and I show details, does it then show each individual insurance carrier's price?
Yes.
It
yes.
does.
So
that's real powerful for someone who with insurance that wants to use it.
Yeah. So once you click this, for some reason I need to buy my own subscription, which was working 1 hour ago. Let me get out of here. Here it is. But you would see the heat maps, which I post on LinkedIn. That's what you will see. You will see all those prices. But I just love that, we have all the clinics. And this is HCA. Anybody without prices, we're posting them in here. So we invite everybody to give me your prices, and I will load them. Clinics, urgent care, imaging centers, HCA. We will load every price you make available to us, which will be available to the consumers, which will help you.
Is this Billy.app right now? I know it's going live today, right? You're releasing it today. Is your vision to do this, B2C or B2B? So
So right now it's B2C. It's B2C, but in the Consolidated Appropriations Act, every employer has to give their employees a cost comparison tool, which is Billy. So we can do like a bulk discount. If an employer wants to give us money for their employees, we can figure out a price point, a discount, so you can be compliant with the CAA. So it's B2C. We could do B2B, but this is about changing healthcare from a third-party payer to a first-party payer.
And when the healthcare ecosystem realizes that business is going elsewhere because they've been caught with their hand in the cookie jar. I mean, it's not going to happen overnight. We already agreed on that, but doesn't mean it shouldn't happen, and it must happen. If this is part of the solution, right? This is the I always bring it up, right? Cy Sims, an educated consumer is our best customer.
Yes.
Right? And markets will change. Just because you can't make the same profit you were making before doesn't mean that other people who are not in the business, weren't used to making that amount of profit, aren't going to see this as an opportunity and say, hey,
Right. And
we can open up a facility, post the cash price. We can disclose. We'll accept the lowest cash price that you can find. I mean,
right.
it's going to happen.
Jeff Bezos says it best. Your margin is my opportunity.
Yes.
Competition fixes all problems.
I love that. Your margin opportunity.
And so Billy is about disrupting the status quo.
Yeah.
And the status quo, actors cannot survive.
Right.
You cannot tell somebody, I want to give you a great deal at 140% of Medicare when the cash rate is $500 cheaper.
Right.
That makes no sense.
And there are companies, so that the consumer understands, right? Because everybody is been so groomed by managed care. Everybody thinks, oh, the only system that exists is my insurance network, right? The Buca networks, the Aetnas, the Cignas, the Blue Crosses, the Uniteds, the Humanas, the Kaisers of the world. That's what people think, not only as their health insurance, they actually think about it as their health care, right? There are companies already working, especially with self-insured groups, right? So once you self-insure, which we're a big proponent of, I think most companies out there that are large enough to be experience rated in their market, and that's different in different states, there's an opportunity in self-insurance. There's companies that are already working, especially with independent TPAs, and we're gonna hear about them, today and tomorrow at Health Rosetta, because I'm at the conference. We're going to talk about companies that were able to really significantly change the paid claims within their plan by using companies like cash pay systems, right? So there's a lot of different types of systems out there, and people are having success with all of them. Reference-based pricing, is probably better than the insurance discounts in most cases, but there could be pushback. But people are great at it. There's people that are great at it. At the end of the day, it's the consumer who's going to decide, what am I comfortable with? How much disruption am I okay with? How much change am I okay with? But if you have a company working with your TPA that says, we're negotiating our own direct contract, that's a different form, right? Versus the published cash price. But if you can pay cash at the time of service or even before the service is rendered, that is extremely valuable for that facility, because when that person walks in the door with that $17,000 deductible and 3 weeks later finds out it's $9,500, do you know how much of that gets unpaid?
All of it.
Just because I can bill $17,000 doesn't mean I'm ever going to collect $17,000. Right. Maybe $4,000 is the fair price for that service, and I'll take that every day of the week. If everybody that came in paid me $4,000, my net is going to be better than I am trying to collect from people that I'm trying to bill $17,000 from, or $95,000.
So I'm really excited that we're embarking on mobile app. It's been the mission of Health Cost Labs. It's been hard getting here.
Yeah.
But we're about disrupting. We have no investors. We don't want anybody telling us who we can't disrupt. I have no expectation of an ROI, no beating down my door. We're here to do the right thing and bring consumerism to healthcare and let the cards fall where they may.
Does Billy like to be called Bill or Will or Billy?
It's Sir William to a few people who I don't like, but it's Billy to everybody else.
My dog Brandy was Sir Brandon de Brook when we lived in Minnesota when I was younger. You had to give it an official name, and yes, his name was Sir Brandon de Brook. But this is awesome.
Thank you so much. And we also have the data from Directs, Scriptco, and Cost Plus Drugs. That'll be coming in like version 2 or 3. So
okay.
You'll have direct e-pharmacy prices, so you can compare them in one screen, so you can make your own informed decision.
That's great. There's going to be a lot. Are you going to Health Rosetta?
No, I'm not.
About that. So it's this is incredible. I know this has been you've been working on this tirelessly for the last how many years now? What, 19 since 2019? 4 years?
I've been fighting, healthcare for 15 years now. Back at Blue Cross, trying to change things. So it's been a long road for me, and I feel that this is where I'm going to hang my hat and say, this is I've accomplished something.
Yeah. Well, good for you. You know what? It's I know that when I changed, the course of my career in 2017, it was a scary time. I wasn't sure, and I found new purpose in being able to, help. I hate to use the word disrupt, but what you're doing is disruptive, and I think in a very positive way. When you're selling insurance to consumers, they don't like the idea of disruption. I know Dave Chase. He didn't like that word as describe what they're doing either. But it's change is necessary, and you can complain all you want or say, oh, this isn't going to work, or this information is not useful. Any information that makes the consumer more informed is useful. The consumer will decide what they want to do with this. Hopefully, they'll use it, and they'll use it a lot, because then healthcare and health insurance has to change.
This is the good RX of healthcare, of hospital prices. And
true. Yeah. And look how successful they are.
Yeah. So this is the good RX. So people are still going to need insurance for stuff they can't afford. But and you said it earlier, just because you can bill $10,000 doesn't mean I should pay you $10,000. So insurance is only for catastrophic care. Your major inpatient surgeries, your cancer, that's about it. Everything else you can find at an outpatient center or at a lower rate, and you'll never hit your deductible.
I know I believe you've spoken to Marshall Allen when we connected. And I'm just thinking of this. How powerful is this to have this information when you know in advance that facility, so maybe someone doesn't change their behavior, right? Maybe someone doesn't know ahead of time necessarily, but they just write on there when they go into the hospital and they have all that paperwork that you have to sign, right? And Marshall's big about educating the consumer, right? Letting them understand their rights and protecting them from a very predatorial healthcare system, unfortunately, right? It's for something so important. It's amazing how predatorial it is and how uncaring it is for the individual. But if you knew in advance that you were going into that facility because you liked your doctor and your doctor has admitting privileges to this one particular hospital, but you know that the cash price or the average price is X, and you just wrote on there when you signed it, say, I agree to pay up to your average price.
Yes.
As disclosed by Health Cost Labs, Billy.app.
As disclosed per your machine readable file.
Right.
That'll
stand up in court.
It will. This data is factual.
In my opinion, I'm not an attorney.
I'm not either, but there's no way anybody should pay more than the machine readable file best price.
Yeah.
Now, I understand that best price may be the Medicaid or maybe too low, but we don't want to get ripped off. So sure,
correct.
Then maybe it's the minimum commercial rate.
Perfect. Yeah, it has to mean something, because guess what? Take me to court.
That's right. Take me to
court, and let's see if the judge sides with you.
No.
When they see the information and they're sitting back there and says, wait a second, your lowest price, your cash price is this, your lowest price is this, your average price is this. Just because they have that logo on their ID card, you're charging them $5,200 when you accept $400?
No.
I rule in favor of the defendant. Thank you. You should refund them $970.
That's right. It's going to fall apart. This whole medical bankruptcy, this bill charges,
right.
It's all going to fall apart.
Yeah. So, even me, who's, I think of myself as pretty forward thinking and really trying to, be an advocate for our clients and their members, especially when they become patients and they enter the healthcare system. Right. having this information and saying, hey, why don't you use this? It's $10 a month. It's $10 a month. Hey, Mr. Employer, let's talk to Leo and his team and say you have 100 employees, you have 200 employees, you have 500 employees. Maybe they'll give us a discounted rate. Or TPAs. The TPAs are going to want this information, and they might build it right into their platform potentially. There's so much possibility with this, and the more people that are aware of it and get upset by it, the better. I think that really is the point of this, is that we want the consumer to get on the edge of their seat a little bit and say, wait a second, do you mean to tell me that my healthcare system or my insurance company has been taking advantage of me for these number of years, and that I have the insurance plan that I have today, this very high out-of-pocket cost, because of the manipulation of all the numbers, all of that,
that's why
contractual stuff that he used to do.
The problem in healthcare is ethics, and there's no moral compass.
Yeah.
And I just really hope the insurance companies will just come to their moment and say, this is wrong. We're just going to accept the lowest amount the hospital accepts as payment in full and reimburse the member that amount. Because this whole price rigging thing is false. So let's stop pretending it's a legitimate business when it's not.
Right. Agreed. Wow. Well, congratulations on this. I could see the excitement. Hopefully 6 months from now, a year from now, you'll be back on. You'll be able to tell us, we have 10 million subscribers.
I would love to.
And the stories, I got to get a panel together. There was a guest, and it's terrible because I don't have my list with me, but I had a guest on, probably about 15 episodes ago. And that's all this company did was, the cash rate, the cash, we pay cash,
Right.
We have a direct contract. We pay cash. And, the providers, the facilities, this is great for those facilities that don't have this feeding system of doctors and specialists that now are employees of the healthcare system that are driving people to where the care is the lowest value, like high price with no better, quality. There's a lot of independent facilities that struggle because they don't have the traffic coming in that do accept a lot less. And that's really what's really powerful when you start talking about all of the independent facilities and the clinics and the labs and things like that. Once that data, becomes even more abundant in your system, they'll win because they are delivering equal.
That's how capitalism works. It's competition.
Yeah.
That's it.
Yeah. Right now, people don't understand that their doctor, when they work for the ABC healthcare system, is an employee of that system. They're told where to send people. And they're not told where to send people because this is where you can get at the lowest price. It's where the healthcare system maximizes their profits. They don't.
So this is going to change that conversation.
Yeah. They don't ask you, oh, how many of your 7 medications are you taking? They don't ask you, what's your out-of-pocket cost ahead of time. They want to know your out-of-pocket cost so that they can get paid because they know you're coming in. But when they're referring you somewhere, they don't say, oh, let's look at your plan. And, your out-of-pocket cost for radiology is subject to your deductible and co-insurance. And this is a $5,000 test with your insurance plan. There's a facility next door that will, that's independent, that'll take $500 cash today. No one's helping. No, I shouldn't say no one. There are plenty of people helping. There's health plans being built, and we'll hear about them again. I like to plug Health Rosetta because it's an amazing organization, but just not enough of it. Not enough of it, and it's because of all that compass right now points towards Wall Street and private equity, and we need to change that. We need to put the consumer in control. So this is amazing. We're coming right up on the hour, so it's awesome. Congratulations on everything, and we'll talk real soon.
Okay, talk to you then.
Thank you for your time today. Bye.
Bye.